welcome to the deep dive.
Great to be here.
Today, we're really getting into it. We've got a set of learning tools, basically some key images from a PDF, and they are just packed with information that's, well, crucial for you, the nurse practitioner student.
Absolutely. We're covering a lot of ground, aren't we? From like the real basics of pharmacology.
Yeah, the foundational stuff.
Right through to specific drugs, clinical situations you're definitely going to encounter.
Think of this as a focused mission. We're looking at these visuals.
Right.
And we're going to pull out the most important bits, connect the dots,
And really highlight why it matters in practice. Why these facts help you prescribe safely, effectively. That's the goal.
Exactly. So we'll walk through them, maybe group things by topic or medication where it makes sense.
Sounds like a plan. Build up that bigger picture.
We'll discuss each point, make sure it's clear, not just what it is, but why you need to know it.
Let's do it. Let's dive in.
Okay, first up, we have Image 6, titled Pharmacology Terminologies. This feels like the right place to start, doesn't it? The basic language.
It absolutely is. You really can't build a house without the foundation, right?
Right.
Understanding these terms, it's fundamental. Without them, how do you really grasp what drugs are doing or how the body is handling them? It underpins everything else.
Yeah, it moves beyond just memorizing drug names.
Exactly. It's about understanding the process.
Okay, so let's hit the big ones first. Pharmacokinetics versus pharmacodynamics. The image defines kinetics as movement of drugs through the body, ADME, and dynamics as the effects of drugs. What a drug does to the body. Can we simplify that a bit?
Sure. Think of it like this. Pharmacokinetics, or PK, is everything the body does to the drug.
Body on drug. Okay.
Right. The drug gets in, and then what happens? Absorption, distribution, metabolism, elimination. That's your ADME.
ADME. Let's quickly break those down. Absorption.
That's how the drug gets from where you put it, like the gut, if it's a pill, or a muscle, if it's a shot, into the bloodstream.
Okay. Distribution.
How it travels around the body and the blood, reaching different tissues, hopefully getting to where it needs to work.
Metabolism.
That's the body changing the drug chemically.
Yeah.
Often breaking it down, usually in the liver, getting it ready to be removed.
And elimination. Getting rid of it.
Exactly. How the body removes the drug or its metabolites, mostly via the kidneys, into urine, but sometimes other ways too, like bile, feces, even sweat or breath.
So PK is the drug's journey and transformation driven by the body. What about pharmacodynamics, PD?
That's the flip side. Drug on body.
Okay.
It's everything the drug does to the body, how it works, its mechanism of action. Does it block a receptor? Activate something? That's dynamics. It covers both the good effects, the therapeutic ones.
And the bad ones, the side effects.
Precisely. Both come from the drug interacting with the body's systems.
So why is it so important for you as an NP student to really get both PK and PD?
Because they're completely intertwined. You can't make good prescribing decisions without considering both. PK helps you figure out dosing, frequency, like how fast will it start working?
Based on absorption.
Right.
Yeah.
How often do I need to give it to keep levels up? That relates to elimination. And how does, say, poor kidney function change things? That's PK.
Okay. And PD helps with?
Choosing the right drug for the problem. What effect are you actually trying to achieve? What side effects might pop up because of how this drug works? You need both to predict how a patient might respond, to adjust doses, to manage problems safely.
It really paints the full picture. Okay, the image also lists AUC area under the curve. What's the clinical takeaway there?
AUC represents the total drug exposure over time. Imagine plotting the drug concentration in the blood on a graph against time.
Right.
The AUC is literally the area under that concentration curve. A bigger area means more drug exposure for longer.
And why does that total exposure matter?
Well, for many drugs, the AUC correlates directly with either how well the drug works, its efficacy, or its potential for causing harm, its toxicity.
Ah, okay.
So, for example, some antibiotics need to maintain a certain AUC over 24 hours to kill bacteria effectively. Comparing AUCs helps us see if different formulations are equivalent or how changing a dose impacts overall exposure. It's a measure of the drug load the body experiences.
Got it. Total exposure. Now, related to concentration, we have Cmax peak and Smolman trough.
Yeah, these are specific points on that concentration curve.
Yes.
Cmax is the peak, the highest concentration the drug reaches after a dose.
The maximum level.
Right. And Sumin is the trough, the lowest concentration, usually measured right before the next dose is due.
And why are we measuring peaks and troughs? Why care about the highest and lowest points?
It's especially important for drugs with a narrow therapeutic index.
Meaning the dose that works is really close to the dose that's toxic?
Exactly. For those drugs, you need to be precise. The peak, Cmax, helps ensure you're getting levels high enough to be effective.
Like killing tough bacteria.
Yes, but not so high that you cause immediate dose-related toxicity. The trough, climb-in, is crucial to make sure the level doesn't fall below what's needed between doses.
So it keeps working.
Right. But also to check for drug accumulation. If the trough level keeps creeping up with each dose, it means the body isn't clearing the drug fast enough, and the risk of toxicity builds over time.
Vancomycin comes to mind.
Classic example. Trough monitoring is standard practice for Vanco.
So peak for immediate efficacy toxicity, trough for sustained effect and accumulation risk. Makes sense.
And that leads right into the last term here. MIC, minimum inhibitory concentration.
Defined as the lowest concentration of an antibiotic that will inhibit the growth of organism.
Right. It's a lab value specific to an antibiotic against a particular bug. It tells you the minimum amount needed just to stop that bacteria from multiplying in the test tube.
The image says the lowest MIC is the optimal antibiotic. Is it always that simple?
Well, it's a factor, but maybe not the whole story. A low MIC is good, but what really matters is whether you can safely achieve drug concentrations at the site of infection in the patient that are significantly higher than that MIC.
Ah, so connecting the lab value back to the patient.
Exactly. This is where PK and PD meet microbiology. You need the drug's PK profile, its absorption distribution, to deliver enough drug to the infection site.
So that the concentration there, the PD effect, stays above the bug's MIC for long enough to work.
You got it. It's about achieving adequate levels in vivo, not just having a low MIC in vitro.
Okay, that really ties those concepts together. So wrapping up this foundational section, the big takeaway for an NP student.
Master these terms. Seriously, they're not just vocabulary words. They're the tools you use to think critically about every single drug. They help you understand individual patient differences, predict responses, interpret drug levels.
It moves you from just following recipes to actually understanding the cooking.
Well put. It's the foundation for rational, safe prescribing.
Okay, let's shift from the general principles to some specific clinical stuff. Hematology seems like a good place to start, specifically anemias. Image 1, top part, talks about common causes of iron deficiency anemia. You're going to see this a lot.
Oh, constantly. Iron deficiency is probably the most common anemia worldwide. And this image makes a really important distinction right away. The common causes differ between adults and kids.
Right. For adults, it lists peptic ulcer disease, PUD, NSAID use, and cancer, specifically colorectal cancer. What's the common theme there?
Blood loss. Usually slow, chronic blood loss from the gastrointestinal tract.
And why is it so critical for you as an NP to immediately think GI blood loss when you see iron deficiency in an adult?
Because you have to find the source. Simply giving iron pills isn't enough if there's an underlying bleed. You could be missing an ulcer that needs treatment, or worse, delaying the diagnosis of something serious like colorectal cancer.
So the low iron is a signal, a red flag, to investigate why.
Absolutely. Especially in older adults, unexplained iron deficiency warrants a GI workup.
And this contrasts sharply with children, where the image lists low dietary intake and iron-deficient diet.
Exactly. In young children, toddlers especially, it's often an intake problem. They're growing fast, their iron needs are high, and maybe their diet isn't keeping up. Too much milk, not enough iron-rich foods.
So the line of questioning is totally different. Diet history for the child
versus GI symptoms, medication history like NSAIDs, cancer screening history for the adult. Age makes a huge difference in your differential diagnosis.
Clear distinction. Now let's look at image 10, another type of anemia. Causes of G6PD anemia. This focuses on triggers.
Right. G6PD deficiency is different. It's a genetic condition where red blood cells are fragile, basically. They lack an enzyme that protects them from oxidative stress.
So certain things can trigger these fragile cells to break down. Hemolysis.
Precisely. And the image gives us a handy mnemonic for common drug triggers, and SPD.
Then SPD, let's unpack it. A.
Aspirin. N.
Nitrofurantoin.
Yep, common UTI drug.
S. Sulfonamides, sulfa drugs.
Also common antibiotics.
P.
An antimalarial. And D.
Depsone, used for things like leprosy, certain skin conditions.
So these specific drugs can cause oxidative stress that overwhelms those deficient red cells, leading to hemolysis.
And the image notes specific demographics are more prone to this.
Yes, it's much more common in males of African, Mediterranean, or Southeast Asian descent. African American males have a significant prevalence. Females are usually carriers, less often affected clinically.
Why is knowing that demographic link so important for you in clinic?
Because it flags patients at higher risk. If you have, say, an African American male patient and you're thinking of prescribing nitrofurantoin for a UTI,
You should pause and consider G6PD deficiency.
exactly, you might screen for it first with a blood test. Prescribing one of these drugs to someone with undiagnosed G6PD can trigger a severe hemolytic crisis. It's a preventable adverse event if you know who's at risk.
A perfect example of using patient demographics for safer prescribing. Okay, let's loop back to treating iron deficiency. Image 5, bottom section, covers interactions with iron supplements. This is huge for patient counseling.
It really is.
Yeah.
Iron supplements are notoriously tricky. They don't get absorbed well on their own, and lots of things interfere with them.
So you can prescribe it perfectly, but if the patient takes it wrong...
It might not work at all. The image gives another great mnemonic: don't iron bad quilt, for things to avoid taking at the same time.
Bad quilt. Okay, what does iron bind to?
B. Bisphosphonates. Drugs like alendronate for osteoporosis, antacids, think Tums, Mylanta. Also, H2 blockers and PPIs can reduce absorption by changing stomach pH, though this mnemonic focuses on binding. Dairy, milk, cheese, yogurt. Calcium interferes.
Glutathione.
The fluoxetine antibiotics like Cipro,
Oh.
levothyroxine, thyroid hormone replacement,
Tetracycline.
tetracyclines, another class of antibiotics like doxycycline.
Wow, that's a lot of common stuff. Other meds, antacids, even food like dairy. What's happening?
They basically bind together in the gut. Chelation.
Mm.
It prevents both the iron and the other substance from being absorbed properly. It inactivates them.
So you lose the effect of both. The image gives practical advice about antacids.
Yes. Wait about 4 hours after taking an antacid before taking the iron pill.
4 hours. That gives the antacid time to clear out.
Generally, yes. It minimizes that direct binding interaction in the stomach or upper gut. Similar spacing principles apply to the other interacting substances too, usually 2 hours before or 4-6 hours after.
And another key counseling point from the image, take iron tablets with plenty of water to help prevent constipation.
Oh, absolutely mention that. Constipation is a really common reason people stop taking their iron. Simple advice like drinking more water can make a big difference in adherence.
So wrapping up hematology, key takeaways for the NP student.
Think beyond just the low H&H. Understand why the iron might be low. Is it intake, kids, or loss adults? Screen for G6PD in at-risk populations before prescribing trigger drugs. And counsel on how to take iron supplements properly, timing with food, other meds, managing side effects like constipation. It's about the whole picture, from diagnosis to effective treatment and patient education.
All right, let's dive into the heart and kidneys, cardiovascular and renal drugs. Huge categories. Image 9, top section, ACE inhibitors and ARBs. The image uses a simple mnemonic for common uses. 3 little words.
Yeah, that's a quick way to remember the big ones: HTN, hypertension; DM2, type 2 diabetes; CKD, chronic kidney disease; and CHF, congestive heart failure.
So the poprils like lisinopril and the sartans like losartan, why are they such cornerstones for all these conditions?
Because they target the renin-angiotensin-aldosterone system, or RAAS. Blocking this system lowers blood pressure, yes, but also does more. It reduces the strain on the heart and, importantly, protects the kidneys, especially in diabetes and early CKD. They have beneficial effects beyond just BP lowering.
The image gives some more specifics, too, beyond just the mnemonics.
It does. It notes their first line for heart failure, specifically LV failure, and can actually improve the LVEF, the heart's pumping function.
Improve function, that's significant.
It is. Also crucial post-MI, after a heart attack, to help prevent harmful remodeling of the heart muscle. And it highlights their use in HTN with mild to moderate CKD, specifically stages 3A to 3B, where the eGFR is between 30 and 60. That really emphasizes their kidney protective role in that population.
So, true organ protection. But there's a big caution note, too. Avoid in severe CKD, eGFR, less than 30.
Why?
Hyperkalemia. High potassium levels.
Explain that link. Why does blocking RAAS plus having bad kidneys lead to high potassium?
Okay, so RAAS normally leads to aldosterone release, and aldosterone tells the kidneys to get rid of potassium. When you block RAAS with an ACE or ARB, less aldosterone means less potassium excretion.
All right.
Now, if your kidneys are already severely damaged, eGFR 30, they struggle to excrete potassium anyway. Combine that underlying impairment with the drug effect, reducing excretion further. Potassium levels can climb dangerously high.
And high potassium is bad for the heart rhythm. Very bad. Can be life-threatening. So the takeaway for you is crystal clear. When using ACEs or ARBs, especially if there's any kidney impairment, you must monitor kidney function, eGFR, and potassium levels. Baseline labs, follow-up labs, non-negotiable.
Got it. Critical safety point. Still on image 9, bottom section, we have alpha-1 blockers.
Right, the OSIN drugs. Terazosin, doxazosin, tamsulosin are the examples given.
Oosine, and how do they work?
They block alpha-1 receptors. These receptors are in the smooth muscle of blood vessels.
So blocking them causes vasodilation, lowers blood pressure?
Correct. And they're also in the smooth muscle around the prostate and the bladder neck. Blocking them there causes relaxation.
Relaxation of the prostate and bladder neck that connects directly to their main use listed. Initial treatment for BPH, benign prostatic hyperplasia.
Exactly. That relaxation opens up the channel, making it easier to urinate. It helps with all those annoying BPH symptoms, weak stream, hesitancy, urgency, getting up at night.
The image makes a distinction, though, between terazosin, doxazosin, and tamsulosin, Flomax.
Yeah, that's a useful clinical pearl. Terazosin and doxazosin block alpha-1 receptors pretty much everywhere, blood vessels and prostate. So they treat BPH and they lower blood pressure quite effectively.
Okay.
Tamsulosin is more selective. It preferentially targets the alpha-1A receptors, which are mostly in the prostate. So its main effect is on BPH symptoms with less impact on blood pressure.
Less BP effect. But the image says it can still cause orthostatic hypotension, dizziness on standing.
It can, yes. It's less likely or less severe than with the non-selective ones, but the risk is still there, especially when starting the drug or increasing the dose. So you still need to counsel patients about it.
So this difference helps with choosing the right drug.
Definitely. Patient with BPH and high BP, maybe terazosin or doxazosin makes sense. Patient with BPH but normal or low BP or prone to dizziness. Tamsulosin might be a better choice, tailoring it to the patient.
Makes sense. Let's move to calcium channel blockers. Image 2, and it's repeated in image 3, focuses specifically on the non-DHP type. It says they work centrally on the heart.
That's the key distinction. Unlike the DHP calcium channel blockers, the ADPins, like amlodipine, which work mostly on blood vessels,
Right.
these non-DHPs, specifically verapamil and diltiazem, have major effects directly on the heart muscle itself and its electrical system.
And what are those effects on the heart?
Two main things. Negative inotropy, meaning they decrease the force of contraction, make the heart muscles squeeze less hard.
Weaker squeeze.
And negative chronotropy, meaning they decrease the heart rate by slowing down electrical conduction through the AV node.
Slower rate. Okay, so weaker squeeze, slower rate. That mechanism directly explains their uses and their dangers.
Exactly. The main effect is lowering heart rate, so the main side effect is bradycardia, slow heart rate. And their uses listed here are for tachyarrhythmias, subventricular tachycardias, SVT, and atrial fibrillation, AFib.
Why are they good for SVT and AFib?
Because they slow that conduction through the AD node. In AFib, this controls how many of those fast, irregular atrial beats get through to the ventricles, slowing the overall heart rate down. For some SVTs, they can actually interrupt the abnormal electrical circuit.
But that same slowing effect makes them risky in certain situations. The image lists contraindications: bradycardia, AV block, specifically second and third degree, and heart failure with reduced EF.
Absolutely. If a patient already has a slow heart rate, bradycardia, or a significant block in their heart's electrical pathway, AV block, giving a drug that slows things down even more can be dangerous. You risk profound bradycardia or complete heart block.
And the heart failure issue. Reduced EF means a weak pump.
Right. If the heart muscle is already weak, reduced ejection fraction, giving a drug with negative inotropy, one that makes it squeeze less forcefully, can make the heart failure worse. Fluid can back up, shortness of breath can increase.
So before you even think about prescribing verapamil or diltiazem, you need to know the patient's baseline heart rate. Check their EKG for AV block and know their ejection fraction status, especially if they have heart failure.
Non-negotiable pre-screening. Absolutely vital.
Okay, let's tackle a big one. Warfarin Coumadin. We're pulling info from image 4, top, and image 8. This drug needs serious respect.
It really does. It's a vitamin K antagonist, an oral anticoagulant. Very effective, but tricky to manage. Image 4 lists the key indications: AFib, prosthetic heart valves, PE, DVT, and aphospholipid syndrome.
Conditions where you absolutely need to prevent clots.
Right. It works by stopping the liver from making functional versions of certain clotting factors that depend on vitamin K. But here's a crucial point from image 4, the onset. It starts working within, say, 24, 72 hours, but the full anticoagulant effect takes much longer, like 5 to 7 days.
5 to 7 days for full effect. Why is that lag time so clinically important for you to understand?
Because warfarin stops the synthesis of new clotting factors, but the ones already floating around in the blood have to be naturally cleared or used up, and that takes time.
Ah, okay.
This is why when you start warfarin for something acute like a DVT or PE, you almost always need bridging therapy.
Bridging.
Meaning you use a faster-acting anticoagulant like injectable heparin or low molecular weight heparin, LMWH, alongside the warfarin for the first few days. You need that immediate anticoagulation from the heparin while you wait for the warfarin to reach its full effect. Then you stop the heparin.
That makes perfect sense. Critical management point. Image 4 also gives specific target INR ranges. INR is the blood test used to monitor warfarin, right?
Correct. International Normalized Ratio. It measures how long it takes the blood to clot compared to normal. The image specifies the usual target is 2.0 to 3.0, with an ideal goal often around 2.5 for things like AFib or DVT-PE.
But it's different for mechanical valves.
Yes, especially mechanical mitral valves, which are very clot-prone. The target INR is higher, 2.5 to 3.5, ideally 3.0. This really highlights the need for precision. Too low, they clot. Too high, they bleed. It's a balancing act.
And both Image 4 and Image 8 emphasize monitoring. Image 8 uses the R in its warfarin mnemonic for requires monitoring of INR, and Image 4 suggests referral to cardiology or an anticoagulation clinic for initiation.
Yes, because of that narrow therapeutic range and all the things that can affect the INR, initiating warfarin and getting the dose stable requires frequent INR checks, often daily at first, then weekly, then maybe monthly if they're very stable. Anticoagulation clinics specialize in this intense management. While you might manage stable patients later, getting them started safely often involves specialists.
And the antidote if the INR gets way too high or there's bleeding.
Vitamin K, mentioned in both images. Giving vitamin K allows the liver to start making functional clotting factors again.
Okay, let's dig into Image 8's warfarin mnemonic for adverse effects. This seems like a long list.
It is. Warfarin has significant potential downsides.
Yeah.
Let's go through it. W, wound healing delayed. A, antidote is vitamin K. Repeats that key fact. R rash. Fetal warfarin syndrome.
Fetal warfarin syndrome? That sounds serious.
Extremely serious. Warfarin crosses the placenta and is a known teratogen, meaning it causes birth defects, especially if taken during the first trimester. Facial abnormalities, skeletal problems, developmental issues. It's generally contraindicated in pregnancy unless absolutely necessary, like for a mother with a high-risk mechanical heart valve.
Okay, a huge red flag for pregnancy. What's next? A.
Alopecia hair loss. R requires monitoring of INR, again, emphasizing importance.
Yeah.
Interacts with many drugs and foods. We need to talk more about that. And end necrosis skin effect.
Skin necrosis.
Yes, warfarin-induced skin necrosis. It's a rare but potentially devastating early side effect, usually happening within the first week. It involves clotting in small skin vessels, leading to tissue death, often in fatty areas like breasts or thighs. Thought to be related to a temporary imbalance in clotting factors when starting therapy.
Okay, back to I for interactions. Image 8 calls out specific ones.
This is probably the biggest day-to-day challenge with warfarin. The image lists the G herbs: garlic, ginger, ginkgo biloba, ginseng, green tea, and the Fe4 drugs: fluconazole, amiodarone, Bactrim, TMP-SMX, and flagyl, metronidazole.
Why single out these herbs and drugs?
Because they are well-known, potent interactors that significantly increase warfarin's effect, shooting the INR up and raising the bleeding risk dramatically.
How do they do that?
The herbs often have antiplatelet effects or might interfere with warfarin metabolism in complex ways. The FAP4 drugs are strong inhibitors of the main liver enzyme, CYP2C9, that breaks down the active form of warfarin. Block that enzyme and warfarin levels skyrocket.
So the practical implication for you is massive. You need a meticulous medication history, including all OTCs, herbs, supplements.
Everything. And patient education is critical. Tell them about dietary consistency, especially vitamin K intake from things like leafy green vegetables. Sudden big changes in vitamin K intake can throw the INR off. And warn them to always tell any provider they see that they're on warfarin before starting any new medication, even antibiotics, for a simple infection.
That Bactrim for a UTI could be really dangerous if the INR isn't watched closely.
A classic, potentially catastrophic interaction if missed. Constant vigilance is needed.
Okay, let's switch gears to diuretics. Image 4, bottom section, covers loop diuretics like furosemide, Lasix.
Lutes are potent diuretics. They work in the loop of Henle in the kidney, hence the name, causing significant salt and water excretion. Uses listed: edema from heart failure and hypertension. But there's a key qualifier for HTN.
It says not first-line treatment for essential hypertension.
Right. For straightforward high blood pressure without fluid overload or severe kidney disease, you'd usually start with other classes like thiazides, ACEs, ARBs, or CCBs. Loops are more for hypertension with edema, like in heart failure, or sometimes for resistant hypertension, or in patients with poor kidney function, where thiazides don't work as well.
The image lists a contraindication. Sulfa allergy.
Correct. Furosemide and some other loops are chemically derived from sulfonamides. So if a patient has had a true severe allergic reaction to a sulfa drug like Bactrim, you generally avoid loop diuretics.
Side effects are summed up with hypo-KLMN. What electrolytes are we losing?
K for potassium, hypokalemia, M for magnesium, hypomagnesemia, and N for natremia, hyponatremia. They cause significant urinary losses of these electrolytes.
And low potassium and magnesium are particularly concerning for
Cardiac arrhythmias. They can destabilize the heart's electrical activity. So monitoring electrolytes is essential, especially potassium and magnesium, particularly in patients with heart disease or on other drugs affecting electrolytes like digoxin.
Other side effects make sense. Hypovolemia, low fluid volume, and hypotension, low blood pressure, causing dizziness, lightheadedness.
Expected effects if the diuresis is brisk or volume isn't replaced adequately. You need to monitor fluid status, BP, and counsel patients about symptoms of dehydration or low pressure.
And the last one listed is ototoxicity, with the note that it worsens aminoglycoside ototoxicity.
Yes, loop diuretics can damage the inner ear, causing hearing loss or tinnitus, especially at high doses, if given too rapidly IV or in patients with kidney failure. The interaction with aminoglycoside antibiotics, like gentamicin, tobramycin, is critical. Using them together significantly boosts the risk of permanent hearing loss. Be very cautious combining them.
Good point. Now let's look at thiazide diuretics. Image 7 top details their side effects. Hydrochlorothiazide, HCTZ, is a common one.
Thiazides are often first line for hypertension. They work a bit differently than loops earlier in the kidney tubule. Their side effect profile is important to know. The image gives us hyper-GLUC.
Hyper-GLUC. What metabolic changes does that cover?
Hyperglycemia, they can raise blood sugar, so monitor closely in diabetics. Hyperlipidemia, they can increase cholesterol and triglycerides, maybe check lipids periodically. Hyperuricemia, they raise uric acid levels. This is important because it can trigger a gout attack.
And the image explicitly says they're contraindicated in gout.
Yes, that's a firm one. Avoid thiazides if your patient has gout. And finally, hypercalcemia, they can increase calcium levels, usually mildly.
So glucose, lipids, uric acid, calcium, all potentially increased. Significant metabolic footprint.
Definitely something to consider, especially with long-term use or in patients with pre-existing diabetes, high lipids, or gout history.
And like loops, they cause electrolyte issues. Hypo-KLMN.
Yes, they can also cause hypokalemia, hypomagnesemia, and hyponatremia. The risk, especially for potassium loss, might be slightly less dose-dependent than with loops, but monitoring is still necessary.
And one more listed. Bone marrow suppression causing neutropenia.
Less common than the metabolic or electrolyte issues, but potentially serious. Keep it in the back of your mind, especially with long-term therapy or if a patient develops unexplained infections.
Okay, last class in this section. Statins, HMG-CoA reductase inhibitors. We're looking at image 5, top, and image 6, bottom. These are everywhere for cardiovascular prevention.
Absolute cornerstones. Examples given. Simvastatin, Zocor, atorvastatin, Lipitor, rosuvastatin, Crestor. They work by blocking cholesterol production in the liver, primarily lowering LDL, the bad cholesterol.
Image 5 immediately flags the major risk, rhabdomyolysis, particularly with simvastatin and lovastatin.
Rhabdo is the big scary one. Rapid breakdown of muscle tissue, releasing muscle proteins like myoglobin into the blood.
Which can damage the kidneys.
Severely. Can lead to acute kidney injury, even failure. Symptoms are intense muscle pain, tenderness, weakness, and often dark tea-colored urine. While any statin can cause it, the risk varies. Simvastatin, especially at higher doses, like the 80 milligram dose, which is now restricted, and lovastatin seem to carry a higher inherent risk compared to some others, like pravastatin or rosuvastatin.
And certain interactions dramatically increase that risk. Image 5 gives the mafia G mnemonic for interacting substances.
Right. This is crucial for preventing rhabdo. Let's break down mafia GM macrolides, antibiotics like erythromycin, chlorothromycin, A, amiodarone, antiarrhythmic, F fibrates, other lipid drugs like gemfibrozole, fenofibrate. Combining these with statins is particularly risky. A, azole antifungals like ketoconazole, ketoconazole. The I isn't part of it. G, grapefruit juice.
MSG macrolides, amiodarone, fibrates, azoles, grapefruit juice. How do these increase the risk?
Most of them inhibit the liver enzymes, mainly CYP3A4, that metabolize many statins, especially simvastatin, lovastatin, atorvastatin. If you inhibit the breakdown, statin levels in the blood rise significantly, sometimes many-fold. Higher levels equal higher risk of muscle toxicity.
So again, medication reconciliation is key, down to asking about grapefruit juice.
Absolutely. You have to ask specifically. And counsel patients on muscle symptoms, report any unusual severe muscle pain or weakness immediately.
Image 6 gives us guidelines on statin intensity for secondary prevention preventing progression of ASCVD.
Yes, this is based on major clinical trials showing intensity matters for reducing events. High-dose statins, like atorvastatin 40-80 mg or rosuvastatin 20-40 mg, are recommended for several groups.
Who needs high dose?
Patients with known clinical ASCVD, they've already had a heart attack, stroke, peripheral artery disease, etc. Also, those considered very high risk. Maybe they've had multiple events or one major event plus other high-risk conditions like diabetes or CKD. Also, patients with severe hypercholesterolemia, LDL cholesterol over 190, regardless of their calculated risk. And finally, most diabetics age 50-75 with LDL over 70.
And medium-dose statins,
Yeah.
like atorvastatin 10-20 milligrams, rosuvastatin 5-10 milligrams.
Recommended for diabetics age 40-75 with LDL over 70, even without calculating their formal 10-year risk score, according to some guidelines. They generally start here unless other factors push them into the high-intensity group.
Okay, so the takeaway for statins.
Know the risk categories and who needs high versus moderate intensity. This drives your initial choice. Then, counsel extensively about muscle symptoms, the rhabdo risk, review all other meds, even diet for those MFEAG interactions, and follow up appropriately.
All right, final section. Let's cover some other key drugs and concepts from these visuals. Image 4, middle section, dives into the effects of systemic glucocorticoids, steroids like prednisone.
Steroids. Powerful, life-saving drugs for many inflammatory and autoimmune conditions, but they come with a hefty side effect profile, especially long-term. The image uses the big gases mnemonic.
Big ASS. Let's unpack the systemic impact. B.
Blood pressure increase they can cause or worsen hypertension. And bone abnormalities, they significantly increase the risk of osteoporosis.
Yeah.
Lower inflammation, that's usually why we use them, the desired therapeutic effect.
Okay.
Glucose increase, they can cause hyperglycemia, steroid-induced diabetes, or worsen existing diabetes control. The other part of G might reiterate the anti-inflammatory goal, or perhaps relate to growth suppression in children with chronic use.
And the 2 S's.
Skin thinning, leading to easy bruising, fragile skin, stretch marks, telangiectasias, spider nails, and skinny thin extremities due to muscle wasting, proteolysis, often contrasting with central obesity, fat redistribution to the face, neck, trunk cushingoid appearance, though not explicitly in this mnemonic.
So high BP, weak bones, high sugar, thin skin, muscle loss, and limbs. Plus the intended anti-inflammatory effect. That's a lot to manage.
It absolutely is. This list tells you what you need to monitor in patients on chronic steroids. BP, bone density, consider screening prevention for osteoporosis. Blood glucose, skin integrity, muscle strength. It's always a risk-benefit calculation when using long-term steroids.
Definitely. Okay, next, image 7, bottom section. Side effects of methotrexate, another potent drug.
Methotrexate is used commonly in rheumatology for RA, psoriasis, also in oncology.
Yeah.
It's an antimetabolite, and it requires careful monitoring due to significant potential toxicities. The mnemonic here is menthol.
Menthol. What are these key toxicities?
Mucosal damage, stomatitis, sore mouth, ulcers is common. Also broader GI upset like nausea, diarrhea, emesis, vomiting, and nausea. Often linked with the mucosal damage. Nephrotoxicity can cause kidney damage, especially at higher doses or if dehydrated. Thrombocytopenia, low platelets, increasing bleeding risk. It can also cause other cytopenias like leukopenia or anemia due to bone marrow suppression. Hepatotoxicity, liver damage, requires regular monitoring of liver enzymes, LFTs,
And L.
lung fibrosis, a serious, potentially irreversible scarring of the lungs that can occur with chronic use.
Wow. Mouth, gut, kidneys, platelets, blood counts, liver, lungs. Affects so many systems. What does this mean for you monitoring a patient on methotrexate?
It means regular lab work is mandatory. You need baseline and periodic CBC for platelets, white count, red count, LFTs for liver, and renal function tests like creatinine GFR. And you must counsel patients to report symptoms like mouth sores, persistent nausea, vomiting, easy bruising or bleeding, shortness of breath, or a new cough immediately.
Patient education and sticking to that monitoring schedule are crucial.
Paramount for safety.
Okay, let's pivot now. Image 3, middle section, covers the drug scheduling guide. This isn't about effects, but legal classification.
Right. This is about the potential for abuse and dependence, which dictates how these drugs are regulated by the DEA. Essential knowledge for any prescriber. It outlines Schedules I through V.
Schedule I being the highest abuse potential, no accepted medical use.
I've got
Down to Schedule V, lowest potential.
Exactly. Schedule I examples. Heroin, LSD, ecstasy, not legally prescribable. Schedule 2, high abuse potential, but do have accepted medical uses. Examples. Opioids like Vicodin, hydrocodone acetaminophen, OxyContin, oxycodone, stimulants like Adderall, also cocaine, rarely used medically now. High risk for dependence.
Schedule 3, moderate to low potential.
Examples. Tylenol with codeine, ketamine, anabolic steroids like testosterone, moderate physical dependence, potentially high psychological dependence.
Schedule 4, low potential.
This is where many benzodiazepines fall. Xanax, alprazolam, Valium, diazepam, Ativan, lorazepam. Also includes sleep meds like Ambien, Zolpidem, and the analgesic tramadol. Lower abuse potential than Schedule 3.
And Schedule V, lowest potential among controlled substances.
Examples. Cough syrups with small amounts of codeine, like Robitussin AC, Lomotil, diphenoxylate atropine for diarrhea, Lyrica, pregabalin, contain limited quantities of narcotics or have lower abuse profiles.
So why is knowing the schedule of a drug, say, knowing Adderall is Schedule 2 versus Xanax being Schedule 4 so important for you in day-to-day practice?
It dictates everything about how you prescribe it legally. Schedule 2 drugs usually require electronic prescribing, no phone-ins in most cases, often have quantity limits, no refills allowed, requires a new prescription each time, and strict storage record-keeping rules. Schedule 3 and 4 drugs might allow refills, up to 5 refills in 6 months usually, can sometimes be phoned in depending on state law. Schedule V rules are generally the least strict. Knowing the schedule ensures you follow the law, prevents prescribing errors, and helps you manage patient expectations regarding refills and access.
Essential regulatory knowledge. Okay, let's wrap up with Image 3, top section, contraindications for influenza vaccine, a common preventative task.
Absolutely. Flu shots are routine, but you need to quickly screen for contraindications before giving one. This image lists the key ones.
First, age younger than 6 months.
Correct. Standard flu vaccines aren't licensed for babies under 6 months. Their immune systems aren't ready.
Second, severe egg allergy, specifically anaphylaxis needing medical treatment or epinephrine.
This is a critical nuance. It's not any egg allergy. If someone just gets hives from eggs, they can usually get the standard flu shot safely, possibly with observation. The absolute contraindication is for a history of a severe, life-threatening allergic reaction like anaphylaxis. You must ask about the severity of the reaction.
Severity is key for egg allergy. What else?
Moderate to severe illness with fever. If someone is significantly sick with a fever, you generally wait until they recover before vaccinating.
Why wait?
Mainly to avoid confusion. You don't want to mistake symptoms of their underlying illness for a vaccine reaction, or vice versa. Let them get better first.
Makes sense. And the last one, history of Guillain-Barré syndrome, GBS, within 6 weeks of a previous flu shot.
Yes. GBS is a rare neurological disorder. While a causal link between flu vaccine and GBS is debated, and likely very rare if it exists, having GBS occur shortly after a previous flu shot is considered a precaution or contraindication for future flu vaccines. It's a standard screening question.
So, the takeaway for flu shots.
Those screening questions about age, egg allergy severity, current illness fever, and GBS history aren't just bureaucratic. They are essential safety checks based directly on these established contraindications. Ask them every time. #outro.
Wow. Okay, that was definitely a deep dive. We covered a massive amount of really practical, vital information for any NP student.
We really did, from the absolute basics PD, which, apply to all drugs,
Right.
all the way through specific details on anticoagulants like warfarin, diuretics, statins, ACE inhibitors, even steroids and methotrexate, plus those key interactions and safety checks.
We hit a lot of those mnemonics too, ADME, bad quilt, and SPD, warfarin, BIGS, menthol, hyper-GLUC, hypo-KLMN. Those are genuinely useful mental checklists.
They really can be, especially when you're starting out and trying to remember all of the potential pitfalls. We also covered drug scheduling, vaccine contraindications, real-world stuff you need daily.
And for you, the NP student listening, this isn't just trivia. This is the knowledge that builds your clinical confidence. Mastering these details, understanding the why behind them, is what lets you make safe, effective decisions for your patients.
Choosing the right drug, anticipating problems, knowing what to monitor, how to counsel, it all stems from this kind of foundational knowledge.
It really highlights how complex medication management is, doesn't it? The potential for interactions, side effects, the constant need for vigilance.
Absolutely. Even with the most common drugs, there's a lot to consider.
Which leads us perfectly into our final thought for you to take away. Thinking about everything we've just discussed, all the potential interactions, adverse effects, monitoring needs, what is one specific, tangible strategy you can commit to implementing, starting now or as soon as you're in clinic, to make your medication practice safer?
Just one thing. Maybe it's always using an interaction checker, like a specific app or EMR function, for every new prescription, no matter how simple it seems.
Or maybe it's committing to really drilling down on one key counseling point, a critical side effect or interaction for every single medication you initiate with a patient, making sure they truly understand that one thing.
Or perhaps it's about improving your system for medication reconciliation, making sure you capture everything OTCs, herbs, supplements every single time. What's one concrete step you can take?
Something to really think about and put into action. That brings us to the end of this deep dive. Thanks so much for joining us.
Yeah, thanks for listening. Keep studying, keep asking questions, and focus on safe practice.